السلام عليكم ورحمة الله وبركاته الحضور الكرام. أهلا ومرحبا بكم في برنامج التوعية والتثقيف الصحي عن داء السكري، المقدم من جمعية السكري السعودية الخيرية بتوجيهات من أعضاء مجلس الإدارة. يسرنا أن نقدم لكم برنامجنا التثقيفي اليوم بعنوان اليوم الثاني من الاحتفال بمئوية الأنسولين، حيث يحتفل العالم بمرور 100 عام على اكتشاف الأنسولين على يد العالمين فريدريك بانتينغ وتشارلز بيست عام 1921 ليقدم للبشرية واحدة من أعظم الخدمات الإنسانية. والآن ننتقل إلى الفقرة الأولى من البرنامج التثقيفي، وهو محاضرة الأنسولين وداء السكري النوع الثاني، تقدمها لنا سعادة الدكتورة إيمان عبد الرحمن الششة، استشاري الغدد الصماء والسكري ورئيس القسم النسائي بجمعية السكري السعودية الخيرية. أهلا وسهلا بحضرتك يا دكتورة إيمان.
وعليكم السلام ورحمة الله وبركاته. الله يحييكم جميعا. بسم الله الرحمن الرحيم. I will talk today about insulin and all types of insulins and diabetes in general and in particular type 2 diabetes. You know, from these pictures, as you see, this is the man that's represented, or the boy represented in the insulin. And this is actually the actions of the insulin. You see that is the insulin taking the glucose, putting in the cells. This is the simple things or simple pictures about the insulin. Then I will talk about the insulin. As mentioned clearly, that's in 1921 in Toronto. This is the Banting and Best. They are the one discovered the insulin. You know, this is the pictures before and after the receipt of the insulin. In more details, you see this is the boy of type 1 diabetes before receiving insulin. And this just 2 months later after receiving the insulin. At that time, before insulin was discovered in 1921, everyone with type 1 diabetes died within weeks, 2 years of its own onset, because it's a fighters, because they have no insulin. So once no insulin, so most of the patients, they will die from type 1 diabetes. I think it's enough for the discovery of the insulin. Just now we'll talk about what is the insulin. What is the human insulin? The human insulin, which is secreted from our beta cells. So it's about peptides, and it's about 51 amino acids, and it's contain chain beta chain and alpha. Chain A and B. In the B, it's contain about 30 amino acids, and in A it's contain about 20 amino acids. So what has happened? It's this insulin, since this is how it's produced within the pancreas by the beta cell, islet cell of pancreas. We have more than 1 million islets. Alpha cells secrete glucagon, and beta cells secrete the insulin. So what is the precursor of the insulin? This is the proinsulin. Then is the by the enzyme effects, it will release insulin and C-peptide. That's why when we want to measure the activity of the insulin or the activity of beta cell, we measure the C-peptides because it's apart from proinsulin. Then after the insulin secretions is transported into the beta cells by the glucose transport, result in membrane depolarization and influx of the extracellular calcium, fusion of insulin storage vesicles in the plasma occurs, the hexamer release from the cell as the crystal and dissolve to monomer. You know that this is the endocrine. You have the things. You have something to secrete, which is from beta cells. Beta cells secrete the insulin. Then, if you have the good actions, it has to be attached to the receptors. Attach the receptor, then you have the actions of the insulin. So then you got the insulin receptors. So what's the origin of insulin? This is the human insulin secreted by the beta cells. So what we have in practice, insulin, origin of insulin. We have the animal insulin from beef and pork before, and we have the human, which genetically engineered using either yeast or E. coli. And we have now the recent one, which is called analog. So just remember, actually the animal insulin no more. So what we have currently, the human insulin and the analog. So what is the difference between human insulin and analogs? Analogs is genetically modified to alter the absorption rates. So the type of insulin, as I told you, before we have the animals, we have now the human insulin, and we have the insulin analogs. In human insulin, we have the short-acting, intermittent-acting, and premix or mixed-start insulin. For analogs, we have the same things, but because it's analogs and it's modified structures, so we don't have the short-acting, we have more faster insulin, which we call rapid-acting. And we have the long-actings, and we have the mixture of rapid and intermittent actings. We'll talk in details. Just to see, from the 2014 till 2017, you see a lot of the things, a lot about the insulin happens. For example, in 2014, we have the glargine 300s. In 2015, we have the Lispro 200s, and we have the digludid. We have the aspart, digludid aspart 7030, and we have the biological insulin. Then I will talk later on. I will talk. Then in 2015 and in 2017 and upcoming, we have other insulin. We have the faster rapid insulin actings, and we have the fixed dose of long-acting insulin and GLP. So really, in the last 6 years, it's really many insulins coming to the markets. So it's important to know that as the healthcare providers, you know what is the challenges with the use of insulins. For the providers, which we are the healthcare educators or physicians or nurses, so we have the challenge. We should know the knowledge of new and old insulin. As I told you, before we have a human insulin, now we have analog insulin, and every months, 2 or 3 months, we have something new from insulin. So this is challenge for us. We have to be aware about all these types of insulin. The other things for the provider, the selection of the appropriate insulin for the patients. So as I told you, we have many insulin. So which is the best for the patients? And the balancing the control with hypoglycemia. You know, that's the main barrier for the use of insulin is the hypoglycemia. So once your patient develops hypoglycemia, believe me, he will not like to have insulin anymore. The other things for the challenges for the providers, time to address the individual patient issue, fear of with the insulin use. No, till now, with all this advantage, with all this development, still we have patients which are they have the fear and anxiety of using the insulins. Time for education or adjustment during and between the visits. This is the very important things. Once we decide to give the patients insulin, we should be aware about the education. So we have to give time for, then at the end of the lecture, I will show you how to do the education for the patients about the insulin. This is the things that challenge with us for the providers. So what the challenge for the insulin with the patients? Usually they have this fears of what? Fears of injections, insulin, or hypoglycemia. Obtaining and retaining education. So they have these problems and the challenges. So maybe sometimes they have no time to have a full education, appropriate administration techniques. So we know that from practice. Till now, we have some patients still they don't know the best way to have the insulin and the way to give the insulins and the complexity of the regimens. So once you give the patient, for example, 4 injections per day, it's really difficult for some patients. So this is another bill. Alhamdulillah, the cost, because in our country, we're giving the insulin free for everybody, so the cost is not our barrier or challenge. Ability to problem solve issue with their regimens. So again, when you give a patient insulin, and then you tell the patient, do monitoring. So you will have to teach them what they should do with the figures. So if they have blood sugar, for example, 300, what they should do. And when they have hypoglycemia. So education is a barrier. Adjustment to the knowledge and the goals as the disease progresses or with aging and comorbidities. So if I give insulin for a patient with 30, it's totally different about the patient with age 70 and so on. The other things which is very important, type of insulin errors. That's why we are talking today about it, because I will address all these things. So what's the error with the insulin? Unintended drugs ordered based on the variety of the drugs formulation. As I told you, for the short-acting insulin, we have many brands. For the rapid-acting insulin, we have many brands. For the intermittent, we have. For the long-acting, we have. So we should aware, because there is an error. Some proprietary name no for different concentration of insulin. We have now concentrated insulin, which is different about the usual insulin. So if you have a mistake to give concentrated insulin, so the patient will go to hypoglycemia. And again, the problem with the error administration, incorrect insulin dose or timing, incorrect administration of the technique, omission error or extra dosing given, and lack of monitoring, which is very important. Once we decide to give the patient insulin, number two, before deciding ordering the insulin, you should order for monitoring. They should have their glucometers, they have got or continuous glucose monitor by freestyle libre or whatever. So they have to do monitoring. Once they start insulin, monitoring is a must. Okay, now this is pictures just of the whole insulin what we have. So here, the short regular insulin, and we have the rapid insulin, intermediate insulin, long-acting insulin, and the ultra-long insulin. I will talk in detail one by one. Before we talk about insulin, let us know about the physiology. What is the physiology of insulin? You know, normally, there is basal insulin secreted. This is a normal. There is basal insulin even within it. There is basal insulin secreted by the pancreas. And when we eat, either with the breakfast, lunch, dinner, we have peak of insulin. So this is when we eat, so there is insulin secreted from our pancreas to maintain the blood sugars with the normal range. Basal insulin to maintain basal glucose in normal range. This is normal. So what we are trying to give with our insulin, we try to mimic our normal physiology, which is basal insulin and insulin. When we eat, there is secreted insulin. So you know those patients with diabetes, type 1 diabetes, they have not enough insulin and they have some sort of insulin resistance. So when we give insulin, we want to mimic the physiology. This is also very important to know, because the patient, they will come and ask you, so I took the insulin now, when expected to blood sugar came down to normal after eating. So just this is about the type of insulins and the onset of actions. This is back to our basic human insulin. Human insulin, short actings. So usually before, when we are using, now currently we are using the insulin analogs, but before we are using the human insulin, it has to give the insulin half an hour before, because it's the onset of actions is need half an hour. Then you should know for short acting insulin, the maximum effects is 1 to 3 hours and duration 8 hours. That's why in the human short acting insulin, we have a risk of hypoglycemia. Then we'll go to the intermediate act, which is the NPH, our regular NPH. So the onset of actions, 1.5 hour to 2.5 hour. Maximum effects, almost 4 to 6 hours. And durations, maybe from 18 to 24 hours. This is, maybe some people, they still use this type of insulin. This is the human insulin. This is the short acting, and this is the intermediate actings. This is before we are using, and this is the mixed start. Still some patients use it. So this is the human insulin, non-analog insulin. Now we'll go to insulin analogs. So what we mean by insulin analogs is the structure of insulin is modified. Pharmacokinetic properties modified to mimic the physiology. So we're trying with the insulin analogs, the new insulin, to mimic the physiology, which I told you. We have the basal insulin secrete, and we have the insulin, once we eat, it's secrete. So we try with analog to mimic the physiology. Molecular pharmacology of human insulin retained. It's just we change or modify the structure of insulin. So what is the ideal analogs? طبعا if we're looking for something, we look for ideal. So what the ideal for basal and bolus? The ideal for the basal to have long duration of action to mimic the basal insulin for the normal physiology, and flat profile. We don't like to have a peak. We have like our normal physiology secreting the basal insulin, and predictable. So we can predict its decrease or increase the dose. This is for basal insulin. No go for meal insulin or what we call bolus insulin. That the insulin we give just prior to the meals. What we need to be fast onset, short duration of action, predictable. Fast onset, so no needs to have half an hour to give. So in children, and we have to have a busy, so just 5 to 15 minutes we give the dose, then we expect to have the action within 2 hours, they'll subside. So we'll have no risk of hypoglycemia. This is the ideal analog. Now we'll go basal analogs. So what we have basal analog? We have the insulin detamere or levemir. We have the insulin glargine, which we know this is basal insulin. Basal insulin, that means it's work for 24 hours. NPH, they consider as a basal insulin. So we have the analog glargine, levemir, and diclofenac. This is the new insulin. So the basal insulin, the new analogs, so long actings, it's flats, no peak, and stay more than or 24 hours. So what is the characteristic? As I told you, it should be mimics the natural pancreatic basal insulin secretory patterns, should be 24 hours. No distinctive peak, no peak. We don't like to have a peak. We want to have a stable basal. Continuous effect over 24 hours. We don't have to wean out 24 hours, so we don't have hyperglycemia. Minimize the risk of nocturnal hypoglycemia. So when we have to give basal insulin, some sort of insulin basal, it will have nocturnal hypoglycemia. That's early morning. Administration once daily for optimum patient adherence. Come on, when we give the patient once per day, so it's better than to give the patient twice per day. And reliable absorption pattern. So this is the glargine and the insulin detamers. We have now a new ones. We have what we call it. This is the glargine detamer. Then we have a new one. It's glargine 300s, and we have the glutic. So why they give us a more new insulin? They want less variability. يعني بالعربي ما نبغى تذبذبات طلوع ونزول. No, just less variability. نبغى بيكلس. يعني ما نبغى ارتفاع. يطلع له بيك يعني قمة ويرجع ينخفض. نبغى no peaks وشد peakless or flat. ويعطينا secretion for 24 hours. So they found the new insulin like glargine 300 and diclofenac stay more than 24 hours and less variabilities. So one of the new, we know that all of us, we know the glargine 100, which is Lantus. Now we have the glargine 300, which is known as Toujay. It's not something that is concentrated, but it lasts more than 24 hours and less nocturnal hypoglycemia and no peaks. And the important things, whenever we give insulin, our things we want, improve the A1C, and we improve the fasting blood sugar, and neutral in the weight, no weight gain, and the hypoglycemia. In this one, 300 glargine, they found it's really improving compared to the basal insulin 100 for the hemoglobin C, the weight is similar, but the hypoglycemia is really less. So if you have a patient on Lantus and develop nocturnal hypoglycemia, I mean early morning before Fajr prayer develop hypoglycemia, is better to shift them to another basal insulin which is called glargine 300. So in this glargine 300 اللي هو 2J, the number of people needed to treat with glargine 300 to prevent blood sugar less than 50 or severe hypoglycemia is 16. So it's really decreased the rate of nocturnal hypoglycemia. So if I have a patient before on I want patient on 100 or glargine 100 Lantus. I want to shift him to 300. What I will do, it's units, no needs. If a patient taking 30 units of Lantus, I can shift him to 30 units of 2J, units. لكن if a patients على twice NPH, فمثلا for twice مثلا 30 60 units, I'll just reduce 20%. يعني أعطيه مثلا 40 units of glargine 300. This is the glargine 300 بسموه 2J. When في important things, as I told you, there is many pens. So if you want to recognize the type of insulin, usually look to the cap, this one. So usually the 2J is green. واللانتوس طلعوا في الكاب هنا دائما يسموه البيشنتس ويسموه الرمادي. It's purple. ها؟ فدائما to differentiate the type of the bins, look for this one في الكاب هنا. So this is the one green, this is the 2J, this is the purple. هم بيقولوا most of the patients they said gray رمادي, but actually you look for this, the purple. This is the purple, this is the lantus, this is the 2J green. Okay. Then we have another long-acting insulin like glargine 300, which is called Tresiba, Degludec. Again, it stays more than 24 hours, no peaks, and less of nocturnal hypoglycemia. Clear? So now I just طبعا comparing التريسيبا ولا الديجلوديك بالبازل insulin, they found for hemoglobin A1C for the fasting blood sugar is similar, but is better for hypoglycemia, especially the nocturnal hypoglycemia. Again, this is the Tresiba, degludec. Okay. طيب. So just in summary for the basal insulin, this is the Lantus. As I told you, the cap is purple. This is for the Levemir, green. This is for the degludec Tresiba. Tresiba سموه كحلي. Okay. طيب. Just I want to clear for you, basal insulin, that means stay more than 24 hours in the body. So it's once daily. Now they add, so some patients, they take Lantus once daily, and they take another 3 injections, 3 meals, like Novorapid or Abidra or Hemolog, whatever, okay? Now what they doing, which is the new things, they brought this Tresiba, and they add with the Tresiba also rapid-acting insulin, which is called Aspart. So instead of the patient taking 4 injections per day, they will take only 2 injections. The percentage was 70% of degludec, which is Tresiba, and 30% of Aspart. And this can be used in type 1 and type 2 diabetes. So it's really good control for the blood sugar and less injections. Now I will talk about, maybe you hear about another basal insulin, which is called basiglars. So what is the difference of basiglars or biosimilar? We call biosimilar. What is the difference biosimilar and our insulin, Lantus, Tresiba, and 2J? This is all basal insulin. So what was the difference with basiglar? Basiglar is called biosimilar. It's not chemical, biosimilar. So what is mean biosimilar? Just this is the difference between the chemicals, our insulin, and the biosimilar, biological. It's the structure usually complex, and something to notice, it's immunogenicity. Yani it can cause some reactions is with the biological insulin, which is the basiglars. But the efficacy for reduction hemoglobin A1C, for the fasting blood sugars, for the hypoglycemia, is similar to our Lantus. Okay, I think it's enough for the basal insulin. Just I'll summarize. Basal insulin, once per daily. We have in the market now Lantus, Glargine 100. We have Glargine 300, which is 2J. We have the Tresiba, which is the Glidic. This is the long-acting insulin. The new one, 2J and Tresiba, is better than the Glargine 100 in reducing the nocturnal hypoglycemia. So finish from the basal. Now we'll talk about the bolus or meal insulin. Just the rapid-acting insulin. Rapid-acting insulin. Just we're taking 15 or 10 to 15 minutes before meals. So action closely mimics the normal physiology. Remember, I told you this. Once we eat, our pancreas secrete insulin. So we try to mimic our physiology. Rapidly absorbed to control the postprandial hyperglycemia. Quickly eliminated to avoid hypoglycemia. So giving 15 minutes, 2 hours, finish. So no more hypoglycemia. Just treat your meals. Adjustable for mean blood glucose concentration and contents of the meals, easily administered. So what we have rapid-acting insulin, you know, we have the Aspart, we have the Lispro. Aspart اللي نحن نعرفه Novarapid. الليسبرو اللي هو الهيمالوك. So actions is rapid actions. This is the one we have. This is the Novarapid, this is the Himalog, and this is the Abidra. Rapid acting insulin. Need to take it 10 to 15 minutes before meals. Maximum 2 hours, finish. Maybe you'll stay 4 hours, but after the 2 hours, usually no effects. So cover only the meals. Now I'll touch about inhaled insulin. Maybe you heard about the inhaled insulin. The inhaled insulin is not available yet here. So I told you there is a rapid action. This is more rapid. Just inhale the insulin, decrease the blood sugar rapidly. But what's the problem with it? The problem with it is lung disease. If you have a patient with asthma, COPD, or chronic lung disease, we should not give, because you need healthy lungs. Enough for the inhaled insulin. Then remember, this is the usual insulin. We have now what we call concentrated insulin. For example, from the concentrated insulin, if you want to give from the usual insulin 2 units, in concentrated insulin, you take 1 unit. Be careful. So if there is a mistake, so there is something called concentrated insulin. I will not talk to the detail about the concentrated insulin, but you should know there is a concentrated insulin which we use for a patient who require insulin resistance more than 200 units per day. طب في new insulin now. شفت وانا قلت لك I just told you there is a rapid acting insulin اللي هو Novarapid, Himalog, Abidra. It takes only 15 minutes and it will work within 2 hours. Now we have كمان more faster rapid acting insulins, similar to Ofol but slightly faster acting. Still we didn't have it here. So about the concentrated insulin, as I told you, we needed to give it for the patients who requires more than 200 units per day. It's concentrated insulin. So you should not mistake. If patient gave concentrated insulin, patient no need it will go to severe hypoglycemia. This is the concentrated insulin, just to remember. Actually, it's not available here, but don't worry about it. Now we'll talk about something again, importance. So we talk about basal insulin, rapid-acting insulin, just to cover the meals. Now, some patients, they require something is mixed between rapid-acting insulin and intermediate-acting insulin. So we have what we call pre-mixed insulin. Again, we have the mixed arm, which is about 30% of short-acting insulin, and NPH. And we have the analogs, as we have Hemalog and Aspart. For Hemalog, we have mix 25 and 50. Remember, for the Hemalog mix, we have 25 and 50. And if we have for the Nofi mix, 30, 70, like our human mix start. So the pre-mix insulin, this is the things about pre-mix insulin. I will not despair you, but you should know this is the one, pre-mix analog. So we have Hemalog mix 50, we have mix 25, we have this one Hemalog 100s. Okay, so this is for Lily, this is the Hemalog. So maybe you will ask me, when I will use the 25 and when you use the 50? If you have the patient taking a big meals like Ramadan during the iftar, so I can give mix 50 because it will cover this the big meals. 25, this is the usual, like the Nofa mix 30. I give it with them twice per day. طيب, في something new. Basal insulin, like I told you, that receiver, it's now combined with GLP. What's a GLP? GLP, which is, if you remember, maybe you hear about Victoza or liraglutides. So this one, use it for the control the blood sugar as well as reduce the weights. This combination, basal insulin plus GLP, they give it in one injections, and really helpful in type 1 diabetes, reducing the weights as well control the blood sugars. Just to aware about these combinations. So what's the indication for insulin in diabetes? We know, no questions. Type 1 diabetes, they should use the insulin. But now we want to know what type 2 diabetes, the age more than 30, when we use the insulin for them. Number 1, pregnant. If pregnant, planning to get pregnant or become pregnant, so should use insulin. This is number 1. Basically, she's type 2 diabetes, but if she's planning or getting pregnant, she should be on insulin. This is number 1. Number 2, acute illnesses requiring hospitalizations. Even patient on oral hypoglycemia admitted to the hospital with infections or whatever the cause of admission to hospital, hospitalized patient, they should be on insulin. Pre-operative, intensive care unit setting, patient going for the surgery, better to control them with insulin. This is basically type 2 diabetes. Post-myocardial infarctions. Once patients have microvascular complication, MI or whatever, so they should be on insulin because good control helping to have not to another infarctions. Or if patients for reason or one that need steroids, so they should be on insulin. Inability to tolerate or contraindication to oral hypoglycemic agent, so they should be on insulin. Newly diagnosed type 2 diabetes. Remember, newly type 2 diabetes, but they have severe hyperglycemia. They have polyuria, polydipsia, weight loss, and the blood sugar high more than 300. So really, the oral, it will not be effective, at least for short duration, 3 to 6 months. Then we'll put them back to oral hypoglycemic agents. Patient no longer achieving therapeutic goal on combination. Next, patients on maximum dose of oral hypoglycemic agent and still not controlling, not achieving the hemoglobin A1C. In these situations, we have to give them insulin. Okay, other things very important, you should know the targets. So most of the patient, type 2 diabetes, hemoglobin A1C should be less than 7. Fasting, they should be between 80 to 130. And peak postprandial 180. And you know that if you want to control, you have to control the fasting blood sugar, 2 hour postprandial, and then if you control the fasting and postprandial, hemoglobin A1C, it will be in the targets. So you should know, as I told you before, insulin therapy options. As I told you, we can give insulin basal alone, we can give bolus alone, اللي هو pre-meal insulin, you can give premix insulin, you can give basal plus 1, you can give basal bolus, and you give يعني basal and 2 bolus, and the full basal plus 3 pre-meals. So if you want to start basal insulin, so the basal insulin, as I told you, we have the Lantus, Lifamir, or Digludic, or 2J. Premix insulin, we have it. Premix, and usually we give twice per day. May need some patient premix insulin, maybe you need some bolus doses before the lunches, and basal bolus. Remember, most of the patients with type 2 diabetes, when we start insulin, or they should continue on metformin. Metformin, we need it in the patients with type 2 diabetes. There is no contraindications. Just to remind you, this is the contributions. When the hemoglobin A1C more than 10, usually the contribution for control is the fasting. So they need basal insulin. But once the hemoglobin decrease toward the 7, they need the contribution for control is the postprandial. As I told you, the best options for the physiological dose is basal bolus, but is according to the patient. What is the regime suitable for the patients? Then just if you want to start insulin for a patient not in insulin, for example, basal bolus. So depended on the weight of the patients. For if you have, you can start 0.3 units per kg per body weight if the patient underweight, old age, or hemodialysis. Remember, this is if a patient underweight, older age, or hemodialysis. I will start 0.3 units per kg per day, okay? Then if a patient normal weight, 0.3 is 0.4. Overweight, 0.5. Obese, 0.6. Clear? Really, once you start the insulin, you have to educate the patient. Education and educations. Frequent blood glucose monitorings. Frequent insulin injections and frequent contacts with the healthcare teams. When we start for our patient type 2 diabetes, the basal insulin. So first target the fasting blood sugar. If you control the fasting and the hemoglobin A1C still not in target, so we have to monitor the postprandials. So now I will give you case. Just I will tell you how to monitor your patient. So I have a patient, 14 years old, type 1 diabetes, على regular insulin, human insulin, NPH 20 or 40. But his fasting blood sugar 190. Remember, the target of fasting blood sugar I told you between 80 to 130. So the fasting blood sugars 190. So what I have to do for this patient? Shall I increase the NPH dose or send the patient home and ask him for glucose monitoring at 3 a.m. or don't do anything and send him home with an appointment after 3 months, or add metformin to him to his insulin regimes. So what the trick in this patient? So this patient having high fasting blood sugar. So once you have fasting blood sugar, you should ask the patient about 3 a.m. blood sugars. Because as I told you, remember, there is nocturnal hypoglycemia. If a patient develops nocturnal hypoglycemia, usually at 3 a.m. So the response of the body release some catecholamine will increase the blood sugar. So you will have fasting blood sugar high due to nocturnal hypoglycemia اللي هي 3 a.m. So this patient, we asked him to do the 3 a.m. So we found the 3 a.m. 50. So what we have, what we called it, Sumogi phenomena or Sumogi effects. So what is the Sumogi? The Sumogi is it called rebound hypoglycemia. Fasting hypoglycemia, but normal blood sugar at bedtime, low at 3 a.m. with the symptoms of hypoglycemia, nightmares, sweatings, hungers, and that. So this is the normal response of the body. They follow hypoglycemia at 3 a.m. So in the morning, you find fasting blood sugar. So once you found patient with high fasting blood, just first ask the patient, do for me 3 a.m. blood sugars, okay? So if you found it low, so what we have to do, we have to reduce the dose of the evening dose of the basal insulin. طيب. The other case, same patients, but found again another patients found the hemoglobin, the fasting blood sugar 190. We did for him at 3 a.m. But we found the blood sugar at 3 a.m. 100. So what is the problem? Why we have high blood sugar in the morning? What we call Darwin phenomena. Darwin phenomena, usually like in pediatric and adolescents, the growth hormone increase overnight. So in the Darwin phenomena, you have to increase the dose or you have to decrease the meals at the night. So what is Darwin phenomena? Darwin phenomena arise in the blood glucose concentration that occurs between 4 and 8 m.m. is due to natural increase in the growth hormone level in early morning. Okay, the other important things, just the insulin injections. So you have to teach the patient how to give the injection and the site of injection. Nowadays, I'm telling my patient, go to YouTube and see where is the site of injection and put it and learn how to put the proper way of in the injections. This, the things, it's, you don't think that it is not common. It's a common. We found it in some patients with using the insulin. What's it called? You see that's the patient, there is like a retractions of the skin. It's called lipotrophy. This is again due to the insulin injection. And this is hypertrophy. So now I will talk about the program of educations. Please, when you start the patients, type 2 diabetes or type 1 diabetes with insulin, you have to do sessions. First sessions, you have to cover diabetes overview and insulin administration, glucose monitoring. Remember, very important. Simple eating guidelines. Don't from day one say, this, you should not eat this one or eat this. Give him simple eating guidelines and teach about hypoglycemia. Should take this session about 90 minutes. This is the initial visit. Then you bring the patient again. So first thing to do it in the second session, just review what you give to the patients. So give them about diabetes, ask them about the monitoring, ask them about monitoring. Asking about the hypoglycemia and the simple eating guidelines. Then add something else like carbohydrate countings. Then the third session. So the first session initial visit within 1 week of the session. The third session should be 2 to 3 weeks after the session 2. So review the skill again. Every time you start the session, before to do anything or give any new informations, review the previous educations. So now you talk about the targets, managing the diabetes when sick, recognize the glucose pattern, self-monitoring, and so on. So in every session, you have the plan, what you do, and then before you start the new things, review with the patients. And this is very important for the educators or even the physician to know every insulin and the onset and working and when stop working. Because the patient, they will ask you, when I take the insulin, we expect it to decrease my blood sugars. If I measure the blood sugar after 4 hours, should be normal or high, okay? And this is you have to teach the patient how to take the injections. The other important things, the storage of insulin. This is very important because some they put it in the fridge, become freeze, so no more longer. Some put it in the car and exposed to the sun. So the storage is very important. Then about the nutrition. You really it's a part of educators to know about the nutrition, not at least the basic nutrition. So if a patient taking basal insulin, how much I need SNAC or not, patient take premix insulin or taking basal insulin and pre-meal. So you have to tell them how to do with the meals and with the snacks. And as I told you, be simple with the patients. Just give them, so sit with the patient and tell them, just tell me about 10 favorite food for you. For example, tell me what fruit you like, what from carb you like rice or bread. So you ask the patient, then you tell them, simple as such. But make simple things, like for example, you tell them the fruits, half cup بتكون 15 gram. So this is the rule of 15 gram. Just tell the patients about these rules and it's simple as such. So the patient, they can manage their, so you know, that's we have some, they like to have a chocolate. Just tell them this a piece of chocolate contain like this. So you have, if you're taking an extra, you have to cover it. For example, if say example 15 gram, I have to give 1 or 2 units of insulin, like this. You have to teach, so you have to teach them to be flexible with the insulin dose. Then the important things for the targets. For example, for the basal insulin, usually the targets, our targets, I told basal insulin, that mean basal insulin, remember, that mean covering the pre-meals and fasting. So our targets 80 to 130. If this one, pre-meals and fasting, more than 80, no change. Less than 180, -2. Remember, or with the educator, take with you 2 to 4 units. Decrease and increase. This is for the post-meals or pre-meals. For the rapid-acting insulins. So just tell the patient, for example, if 90 to 130, just take usual dose. Increase, make it, if the increase 50 milligram, add 1 insulin units. This is for the premix insulin, same things. This is in general for premix insulin. And now, just I want to summarize the things telling you the problem and adjustment and cautions. So if you have uncontrolled fasting blood sugars, so which insulin responsible, you have to adjust the BM basal insulin. Remember, cautions, watch for nocturnal hypoglycemia. Remember, check at 3 a.m. طيب. If you have uncontrolled 2-hour postprandial, so what's insulin responsible? So the responsible adjust the pre-meal insulin, whether regular insulin, rapid-acting insulin, okay? If you have uncontrolled pre-lunch blood sugars, adjust the EM, sometimes patient on NPH, so adjust the AM basal NPH insulin. If you have uncontrolled, this is the 2 for premix insulin. So if you have pre-lunch or pre-dinner high, so you have to adjust the AM. If you have the pre-super blood sugar high, so you have to adjust the basal and the pre-lunch regular insulin. Principle of insulin adjustment. Remember, adjust the insulin dose up or down by 2 to 4 units at a time. Patient might be overly sensitive to hypoglycemia. So don't 2 to 4. That's time. Give new insulin regime time to work. For example, I told the patient, increase your insulin by 2. So give time at least 48 hours, 2 or 3 days. Type. Timing, quality, and composition of the meal is important in determining the type and the dose of insulin. Finally, I will end with some of take-home messages. Number 1, never try to control diabetes with oral hypoglycemic drug without ensuring strict diet controls. So please, taking the medications not mean that's no need to be on diet control. Diet and exercise. Always bring fasting sugar to normal before trying to control the postprandial. Told you before. Fix first fasting. Control any underlying infection, stressful condition. Keep meal timing regular with 6 hours between the 3 meals. Don't inject before 10 p.m. Keep number of calories during the meal same from day to day. The quantity and the quality of diet should be the same at the same timing. I used to tell my patients, if you want to control your blood sugars, please strict with me with some type of diets. Don't take fatty diets. Don't do too much sugar meals, so I can adjust your diabetes. Don't use the sliding scale to calculate the dose of insulin, use proper techniques to inject the subcutaneous insulin, because I want to show this one, the picture I showed you, the hypertrophy and the atrophy. Ensure the proper storage of the insulin. Should tell the patient where they should keep the insulin. And thank you.
Thanks, Dr. Iman. At the end of our lecture, we would like to thank Dr. Iman الششة for her nice introduction for information. Seeing you soon in other educational program, inshallah. Now I'm gonna send you the link for attendee certificate. Thanks all, and wait for our second lecture with Professor ناصر الدغري. وفي ختام محاضراتنا نتقدم بالشكر الجزيل لسعادة الدكتورة إيمان الششة على التقديم الرائع والإلقاء الممتع، على وعد بلقاءات تثقيفية أخرى. والآن سوف يتم إرسال رابط الشهادات في الشات. شكرا للجميع، وانتظرونا في الفقرة الثانية ومحاضرة البروفيسور ناصر الدغري نائب رئيس مجلس إدارة جمعية السكري السعودية الخيرية.
شكرا جزيلا.